I guess we're back from the break. Grab your piece of paper and let's go. Hello and welcome to MK's Exam Secrets. My name is Dr. Moses Kazivu. This is a series on my YouTube channel where we'll look at exam questions in one clinical course. This is season 3, episode 2, internal medicine. If you haven't yet subscribed to the channel, please subscribe to the channel. Hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment, and tell a friend that it is an exam week on the channel. So let's get right into it. You know, the gist of these episodes is that you can pause the video before I give you the question, write down your answer or scream your answer at your screen, whatever works for you. So let's jump right into the first question. So you have a 45-year-old man who presents with a complaint of frequent headaches. His blood pressures were 160/85, 155/90, 162/90 on 3 consecutive clinic visits, despite having initiated a low-salt diet 6 months earlier at your recommendation. He is not taking any medication and does not have any medical problems. You decide to diagnose hypertension and initiate a first-line medication to control his blood pressure. Part A, how is a diagnosis of hypertension made? B, list classes of drugs used in the treatment of hypertension. Give examples under each class. C, the patient later found he was also be diabetic. Which class of drug will you ensure is part of his treatment? D, if endoscopy is essential part of examination of any hypertensive patient, outline the possible abnormalities graded according to the Keith-Wagner classification. Part E, define malignant hypertension. Part F, what is the most common cause? What are the 2 most common causes of death in hypertensive patients? You may pause the video right now. And here comes the answer. So this person had persistently elevated hypertension, or rather persistently elevated high blood pressure. So remember that you have this persistent elevation in arterial blood pressure that's going to be greater than 140 millimeters of mercury systolic and 90 millimeters of mercury diastolic on more than one separate occasion. So meaning at least 2 or more occasions apart. Or if they come in with the presence of an end organ damage, for example, hypertensive emergency, for example, if they have a very high BP with, let's say, hypertensive encephalopathy, or if they come in with a very high BP that's greater than 220/115 millimeters of mercury, then we would make the diagnosis there and then. Then list classes of drugs used in the treatment of hypertension and give examples under each class. So you have the commonly used drugs, which are the ACE inhibitors, your angiotensin converting enzyme inhibitors like enalapril, captopril. You have alternatives, which are your angiotensin receptor blockers or receptor antagonists such as losartan. You have your alpha blockers like prazosin. You have your beta blockers like atenolol. You have your even labetalol. You have your calcium channel blockers like nifedipine and amlodipine. You have your centrally acting drugs which are used in pregnancy like methodopa. You have your diuretics like furosemide as well as thiazide. Thiazide diuretics, the hydrochlorothiazide, and then you also have vasodilators like hydralazine. So the patient was found also to be diabetic. Which class will you ensure is part of his treatment? So you want to ensure that ACE inhibitors, because these are going to be prolonging survival and they're also going to be reducing the complications of diabetes, such as the proteinuria that may be there. Now for the grading, I will show you on the next slide together with pictures so that you have a good understanding of that. Then define malignant hypertension. So this is just simply a very high BP, a systolic blood pressure greater than 200, a diastolic greater than 130. That's going to be accompanied by papilloedema. There is something that's referred to as accelerated hypertension. This is the one that's going to be associated with hemorrhages and exudates. Now, the two most common causes of death in hypertensive patients are your cerebrovascular disease, that's your stroke, as well as your cardiovascular disease, either ischemic heart disease or heart failure. Now, here's the grading. So here you have a normal fundus here. Then here you have grade 1 hypertension or grade 1 hypertensive retinopathy, which is pretty much your mild generalized retinal arteriolar narrowing. So the arteries, the arterioles are going to be narrowed. This is the fundus of the eye that you're looking at over here. Then grade 2, you have a definitive or a definite focal narrowing and the atriovenous nipping. So these vessels actually become very narrow. They become very tortuous. As you can see here, this is someone who's at grade 2. They also appear as if where the arteries and the veins are passing over, it appears like as if they've been nibbled away. Then grade 3 is everything that you had in grade 2 plus your retinal hemorrhages, your cotton wool spots. These are these white spots, these white blotches that you can see. Then that's your grade 3. Then of course your grade 4, you're going to be having everything you had in grade 3 plus papilloedema. You can even see that now the optic disc is becoming blurry, and here this person even had retinal detachment. It's even much more significant. This is the hypertensive retinopathy grading, so keep this in mind. Moving on to question 2. A 58-year-old woman is followed in the nephrology clinic for long-standing chronic kidney disease secondary to uncontrolled hypertension. Her glomerular filtration rate continues to decline, and she is approaching initiation of dialysis. Plans are made to obtain vascular access at the appropriate time. A. Define renal replacement therapy. B. What are 2 common methods of renal replacement therapy? C. Define your answers in B. D. Give indications for dialysis. E. What conditions would lead to end-stage renal failure? So you may pause the video right now. And here comes the answer. So, of course, the renal replacement therapy is going to be a modality that is going to be used to replace the waste filtering function of a normal kidney. So we usually use this in some conditions of acute kidney injury and in some conditions where the patient has chronic kidney disease or end-stage kidney disease. Now, most commonly, you're going to have the dialysis, which can be either hemodialysis or peritoneal dialysis. Other methods include hemofraction, hemodiafraction, even kidney transplantation, which is like the last option. Now, hemodialysis, you're going to have this special machine, which is known as a dialysis machine, which has these special filters. We can refer to it as an artificial kidney or a dialyzer. Now, this is just simply going to filter out the blood. So blood is going to be flowing across or over a partially permeable membrane against another fluid that's going to be flowing in the dialysis machine in the opposite direction, kind of like how it is in the kidneys, where you have the blood going through the glomerulus and then of course filtering out and being carried out by the renal tubule. Similar thing, you have this fluid that is moving in an opposite direction to create a constant gradient between the blood and the fluid, and you have blood also flowing in a constant direction. So some of the solids can actually diffuse down a concentration gradient, and then we can also add some hydrostatic pressure to remove the excess fluid. Then there are 3 types of venous access that we can actually use for this type of dialysis. So you can either use an atriovenous fistula, which is usually a preferable route because it's prolonged. You can keep it there for quite some time. You can use an atriovenous graft. You can also use a central venous catheter. Then, of course, with peritoneal dialysis, you're going to be using the peritoneum as the partially permeable membrane. So the catheter is going to be inserted into the peritoneal cavity, and then we infuse a fluid on the inside. And solids are going to diffuse now into this fluid, and this fluid is going to be pumped out. So we can actually enhance the process of ultrafiltration by adding osmotically active compounds like glucose, even glucose polymers, to this fluid. And then of course this is going to cause even much more filtration from the blood, and then the fluid is eventually removed from the peritoneal cavity. And indications for dialysis, remember your RAEOO, A for acidosis, E for electrolyte imbalances that are refractory to medical therapy, I for intoxication with drugs and alcohol, O for edema, this is fluid overload, and then U for uremia. Then of course, what conditions could lead to end-stage renal failure? There are many. It could be things like diabetic kidney disease, hypertension, vascular disease, glomerular disease, which may either be primary or secondary, cystic kidney disease, tubular interstitial disease, urinary tract obstruction, even recurrent kidney stones can cause end-stage renal failure. Moving on to question 3. Mr. Banda, 49-year-old, has been referred to hematology clinic from a rural hospital for further evaluation and treatment. The referring doctor suspects Mr. Banda has chronic myeloid leukemia, a topic that most students usually do not like. The referring doctor has suggested the Philadelphia chromosome test to confirm the diagnosis. Mr. Banda had been well until the last 1 month, when he noticed that he was getting tired easily and his hearing was getting poor. His past medical and occupational history were unremarkable. Below was his full blood count done at the referral hospital. White blood cell count 423, hemoglobin 10.2, MCV 89, platelets 500. List 4 differentials for leukocytosis other than CML. Name and explain 2 tests that can help you differentiate malignant from non-malignant leukocytosis. Briefly explain the Philadelphia chromosome, what the Philadelphia chromosome is, and its role in the pathophysiology of CML. Other than the Philadelphia chromosome, which other confirmatory test for CML can you order? List the clinical phases of CML. Name 3 drugs that are standard targeted therapy in management of CML. So you may pause the video if you haven't watched the video on leukemias, chronic leukemias. I will leave a card right here on the screen so that you can actually go and check it out and watch those videos. It's very, very important for you to do so. And a big shout out to Tandiwe Banda for actually making all this possible, and I really appreciate. She's done quite a lot of work in the background to help the publication of some of these videos, to help the publication of some of the books that you actually go through. So a big shout out to her. So you may pause the video right now, but here comes the answer. So 4 differentials. 4 things that can cause a rise in the white blood cell count. It could be due to septicemia, which is an infection. It could be a leukemoid reaction due to certain things. Even certain drugs can cause a leukemoid reaction. It could be due to tuberculosis. It could be due to sarcoidosis. I'll show you a slide where I've actually grouped them according to the different white blood cells that are increased. You have the neutrophilia, the lymphocytosis, the eosinophilia, the basophilia, and the different conditions. Let me just show you that right now. So this is the neutrophilia, the monocytosis, eosinophilia, lymphocytosis, and the different conditions. So you can just simply get a screen grab of this, because going through this entire list will be quite exhaustive. So you can get a screenshot of this and then just keep this in mind. Then name and explain 2 tests that can help you differentiate the malignant from non-malignant. So one important thing is peripheral smear. Remember that in the peripheral smear, when you're suspecting that this is CML, you're going to be having a lot of immature granulocytes, and you have these myeloblasts, these immature cells in the bloodstream. And there will be, depending on the stage where you are, there will be a certain percentage. And then of course, a bone marrow aspirate is going to show you increased cellularity, primarily the myeloid and the megakaryocyte lineage. Then what exactly is a Philadelphia chromosome? So remember that you have part of it's what is known as a reciprocal translocation that is happening between chromosome 9 and chromosome 22. So you get a piece of chromosome 9 that breaks out. Now this piece is going to be containing a gene which is known as the ABL gene. Now this one is going to be translocated to chromosome 22, and in chromosome 22 it's going to be fused with the BCR gene, so forming what is known as a BCR-ABL gene. So now this BCR-ABL gene is pretty much going to be producing a certain protein. This protein is known as a BCR-ABL tyrosine kinase, or you can call it as a P210 tyrosine kinase. It's an oncoprotein. Now this oncoprotein, what is it going to do? It's going to deregulate cellular proliferation. It's going to decrease the adherence of the leukemic cells to the bone marrow stroma, so it means they can easily get into the bloodstream. And of course, it's going to protect these cells from the signals that are going to be causing apoptosis, the cell death. So that's how they're going to be contributing to causing leukemias. And of course, the other tests that we can do fluorescein in situ hybridization, or FISH. We can also do reverse transcriptase polymerase chain reaction, even flow cytometry to confirm the diagnosis. The three clinical phases are going to be a chronic phase, accelerated phase, and the blast phase. Again, I've covered all these details in my video on chronic leukemias. I have also done a video on acute leukemias. I will leave a card here again for the acute leukemias. You can just have a check out of that and learn as much as possible. Then the three drugs that are given, the first line, of course, are your tyrosine kinase inhibitors, drugs like imatinib, nilotinib, dasatinib. You may also give hydroxyurea as palliative, even busulfan, as well as recombinant interferon or pegylated interferon. Moving on to question 4. A 17-year-old lady is brought to the emergency room for nausea, vomiting, and abdominal pain. She also reports increased urinary frequency on physical examination. Our vital signs are as follows: temperature 36.3, heart rate 119 beats per minute, blood pressure 90/52, respiratory rate 24, SpO2 100 on room air. She is lethargic and markedly dehydrated with dry mucous membranes and sunken eyes. Her abdominal examination is benign. Laboratory results show serum glucose of 22 millimoles per liter, sodium 146, potassium 5.6, chloride 99, bicarbonate 12, blood urea nitrogenous waste 18, creatinine 74, arterial blood gases reveal pH 7.2, the partial pressure of carbon dioxide 21, partial pressure of oxygen 102. A urinalysis is positive for ketones. What is the diagnosis? Define your diagnosis in A above. What is the patient's electrolyte and acid-base status? What symptoms can the patient with this diagnosis present with? What are the common precipitating events for your diagnosis? How would you manage this patient? What complications can result from this diagnosis? You may pause the video at this moment. Here comes the answer. So as you can see, this person here has, the first things first is we can agree that this person is dehydrated and they are possibly in shock. They are in shock. If we look at their BP, even though their BP is not below 90 systolic, but their diastolic pressure is below 60. So we can agree that they're in shock. They are dehydrated, meaning that they have the dry mucous membranes and the sunken eyes. That's already given to us. Now, this may have been attributed, of course, to the vomiting that is there. Okay, and they are quite anxious. Their BP is 119. Their respiratory rate is 24, so they are quite tachypnic as well. Their blood sugar is very high, 22 millimoles per liter. So it means we should be now thinking of things like that can cause hypoglycemia, so things like diabetes. Now, if we look at their urine, we also see ketones in their urine, and their pH is acidic. Remember that the normal pH is 7.35 to 7.45. So it means this person possibly has diabetes. So this person actually has come in diabetic ketoacidosis, secondary to type 1 diabetes mellitus, in shock. So they are actually in shock. So remember that DKA is pretty much a life-threatening acute severe manifestation of insulin deficiency. That is a complication of type 1 diabetes and presents with hyperglycemia, metabolic acidosis, hypotension, hyperketonemia, and ketonuria. Shock is going to be defined as a state of circulatory failure that's going to be resulting in inadequate organ perfusion. And Type 1 diabetes obviously is also going to be a metabolic disorder that's going to be characterized by persistent hyperglycemia due to insulin deficiency. Now, what electrolyte abnormalities do we have, and what acid-base imbalance do we have in this patient? So as we can see from these results, the sodium here is high, so they're hyponatremic, so its cutoff point is 145, so we can say it is high. Potassium is obviously high, they're hyperkalemic. Chloride is low, so they're hypochloremic. They also have a low level of bicarbonate. Then their blood urea nitrogenous wastes are high, creatinine is normal. Then of course they're in metabolic acidosis because their pH here is 7.2, and of course their bicarbonate has decreased, so they're in metabolic acidosis. And the fact that the partial pressure of carbon dioxide is 21, meaning that it's low, it means that this person here, even the 7.2 is more or less like a moderate type of DKA. Okay, but because of other features that this patient has, like shock, you may bump them up to a severe type of DKA. Then what symptoms can the patient with this diagnosis present with? So mental changes, drowsiness, lethargy, dehydration, so dry mucous membranes, which has already been given, poor skin tagger, nausea and vomiting, which have been given. They may also present you with a leg cramping, weight loss. They may present you with weakness. They may present you with features of polydipsia and polyuria, which I haven't added to this list, and abdominal pains. Now remember that, which they have also listed, remember that Kussmaul's respirations or air hunger, those are signs that you're going to elicit. And the fruity breath also is a sign that you're going to elicit, unless if the examiner really intended to say clinical features as opposed to just saying symptoms for the patient. Now, the common precipitating events are going to be things like infection, poor compliancy with insulin treatment, dehydration, stressful conditions like trauma, surgery, MI, even an emotional crisis, even excessive alcohol intake. How am I going to manage this patient? So first and foremost, you should admit this patient to ICU, or preferably a high dependency unit. Do your ABCs, ensure that the airway is patent, the patient is breathing, gain venous access, draw bloods for investigation. So your urea and electrolytes, which have already been done in this case, your full blood count to rule out any infections, and of course your baseline other tests like a liver function test. Then of course you start running your fluids. Because this person is in shock, you're going to be giving 500 mils of normal saline over 15 minutes. Then you repeat that if they're still in shock. You can give another 500 over 30 minutes. Then when they're out of shock and their BP is greater than 90 systolic blood pressure, you give 1 liter in 1 hour, 1 liter in 2 hours, 1 liter in 4 hours, 1 liter in 6 hours. Then when their blood sugar drops to less than 14, we switch them to 5% dextrose to prevent hypoglycemia. We should also give them insulin, about 0.1 units per kg per hour. Then we reduce it to 0.05 units per kg per hour until when their blood sugar is less than 14 millimoles per liter. In our case here, we usually give 6 international units if they are on the smaller side per hour, or 8 international units if they're on the larger side per hour every hour. Then of course your potassium should be monitored for now because this patient has 5.6, so we don't necessarily have to give potassium. So we catheterize them, ensure that there is adequate urine output. Then if the potassium begins to drop, we can give 20 millimoles of potassium chloride. Cover them on broad spectrum antibiotics, so a good start is your ceftriaxone 1 gram IV twice a day. Catheterize the patient, monitor the urine output, RBS hourly, and then of course monitor the electrolytes as well. The complications that may arise include cerebral edema, which could be a complication of the treatment, coma, hypothermia, pneumonias and DVT, which occur later on, as well as hypochloremic acidosis, which arises due to the treatment. Now the last and final question, I saved this one for the last because, funny enough, this is actually the first question I actually ever did on the series, but it's actually an extended version of the question. They have added some questions to the question. So here it goes. A 32-year-old HIV positive female known to be non-adherent to her treatment regimen presents to the hospital with the complaint of new onset headaches. Her vital signs are only significant for a low-grade fever. Neurological examination reveals right-sided upper motor neuron lesions as well as inattention and difficulty with concentration. A CT of the patient's head shows ring-enhancing lesions. Her CD4 count was noted to be 78 cells per cubic millimeter. What differentials would you consider? What is the most likely diagnosis? What diagnostic serological tests are you going to order? How can one get this condition? What treatment will you give this patient? For how long will you give the treatment? If the patient does not improve clinically or the lesions do not reduce in size, what next step would you take as the clinician? List 5 conditions that are classified under stage 4 of WHO clinical staging of HIV. So you may pause the video right now. And here comes the answer. So this is a patient that has HIV. They're not compliant. Their CD4 count is very low. Then, of course, they come in with the focal neurological symptoms such as right hypersided motor neuron lesions, inattention, as well as difficulty concentration. Then they also have these ring-enhancing lesions. So what do I think this person may have? So they may present you with the CNS toxoplasmosis. CNS lymphoma can also give you a similar picture. TB meningitis, cryptococcal meningitis, even a pyogenic cerebral abscess. Those are the things that I would keep in mind. The most likely diagnosis will be my CNS toxoplasmosis in an RVDR stage 4 patient with poor compliancy. The serological test is known as a Sabine-Feldman dye test, which of course checks for serum IgM or IgG against toxoplasmosis. So you can simply call this a toxoplasmosis antibody test. Now, how can one get this condition? So it's gotten through the ingestion of oocysts in contaminated water or contaminated foods with cat feces. Then, of course, you can also get it from tissue cysts from eating undercooked meat, and in some cases from vertical transmission from mother to child. Then, what treatment will you give? So there are 3 regimens that we can give this patient. The first regimen is going to be combining pyrimethamine, which you give a loading dose, and then a usual dose, a maintenance dose. So pyrimethamine plus sulfadiazine plus folinic acid. The second regimen is giving Fansidar, which is a combination of pyrimethamine and sulfadoxine plus your folinic acid. And the third regimen is giving pyrimethamine, clindamycin, and folinic acid, because there are some patients that are allergic to sulfur-containing drugs, so you would substitute them with clindamycin instead. Then for how long would you give the treatment? So we'll give it for 6 weeks or 3 weeks after complete resolution of the lesions on the CT. Then after that, you continue with the prophylactic treatment until the CD4 count is greater than 200 cells for 6 months. Then if the patient doesn't improve, what am I going to do? I'm going to determine the CD4 count at that point, determine the viral load at that point, and then of course possibly switch them to ART second line, because their immune system isn't really improving, because they probably are resistant to the first line that they're taking because they haven't been taking it right. Then list 5 conditions that are classified under stage 4 WHO. So you have your pneumocystis jirovecii pneumonia, your cryptosporidiosis, your isosporiasis, lymphomas, Kaposi sarcoma, esophageal candidiasis, even extrapulmonary cryptococcosis. This includes cryptococcal meningitis. I really hope you enjoyed that episode of Internal Medicine. Stay tuned to exam week. Tell a friend to subscribe to the channel. Hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.